I'm going to go ahead and get started, and we may have a few more people joining as we go. But thank you, everybody. Welcome. We're glad you're here. Today's webinar is Opportunities to Improve Race and Ethnicity Data Collection. So I'll go to the next slide and introduce today's presenters and hosts. My name is Vicki Quintana. I'm a Senior Program Officer at the Center for Healthcare Strategies. I'm joined by my colleague Ann Smithy, also a Senior Program Officer at the Center for Healthcare Strategies, and Amber Johnson, Director of Quality Improvement at the Colorado Perinatal Care Quality Collaborative, and Katie Breen, Vice President of Quality and Strategy at the Colorado Perinatal Care Quality Collaborative. For those who don't know CHCS, or Center for Healthcare Strategies, we're a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to better ensure more equitable outcomes, particularly for children and adults served by Medicaid. We work to advance more effective care models for care delivery, more efficient policy and program design, and across all of our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity for people facing the greatest disparities. As we get started, I'd like to share a couple of housekeeping items. Please, to help with background noise, mute yourself when you're not speaking. If you're calling in, you can pair your phone and your video so that we can tell who's talking when you participate. We also invite you to rename yourself to include your first name, your last initial, your pronouns, and your organization. And/or feel free to introduce yourself in the chat. Just say who you are and where you're coming from. Also, we welcome your questions, thoughts, and contributions throughout. Feel free to post them in the chat or raise your hand and get ready to come off mute if you would like to share. And last but not least, your feedback is welcome. We'll share a link to an evaluation survey at the end of this presentation, and we'd really like to know your thoughts on how it met your needs. So this is number one in a learning series. Today we're focusing on race and ethnicity data collection. Next, we'll get into understanding quality improvement with a health equity lens. And the third in the series is about strategic communications about health equity and data collection. And the dates are here on the screen. Also, this QR code you can scan that to register, or you can follow the link I'm going to put in the chat in case you're not registered for the others in this series. We'll also share this link again at the end. So for today, we've gone through the welcome and introductions. Next, I'm going to get into fundamentals of collecting race, ethnicity, and language data, or REL data. And then my colleague Anne and also Amber are going to discuss opportunities to enhance REL data collection. And then we should have time for question and answer. All right, so I'll get into framing today's discussion. Why should we focus on collecting race, ethnicity, and language data? So we have several reasons. I also want to invite you to put your reasons in the chat as we're talking. But essentially, collecting race, ethnicity, language, and other information aids in conversations about the care that your patients would like to receive. In other words, it helps engage your cultural humility as you're encountering patients. It also supports your health equity efforts in order to measure disparities and design interventions to reduce disparities and track the impact of those interventions. And it's also required by many state and national programs for purposes that include measuring disparities and closing health inequities. So if you have other reasons for collecting this data, we'd love to hear about them in the chat. And our overall objective for this series is that you'll be able to learn about opportunities to improve your data collection as part of understanding health equity related challenges and quality improvement opportunities. So now I just want to give a brief overview of some of the requirements that you may know about. There are several Senate and House bills that require birthing hospitals to participate in this type of data collection. So for example, birthing hospitals are required to participate in QI projects with CPCQC, which includes the submission of QI data disaggregated by race and ethnicity. CDPHE also is required to prioritize collection of race and ethnicity data, including in birth certificates. The Health Equity Patient Safety Bundle specifically asks hospitals to provide staff education and training on how to ask these questions and how to provide information to patients on why the data are being collected. And the Hospital Transformation Program has several program elements that require patient demographics. I also wanted to mention that there are many federal programs and national accreditation standards that may include requirements to collect patient demographics. Some of these things are changing in the current environment. So we didn't list them out for purposes of this webinar because the state still requires this data collection, and it's still important for shaping your quality improvement efforts with a health equity lens. So now I want to say a few more words about cultural humility. This may be a term you're familiar with, maybe not. Maybe you've heard similar terms, but this is recognizing that the context in which the data collection happens matters. It can be a difficult topic for both you as clinical staff and administrative staff who are collecting data when you're a patient and you're asked for this data, and also for the patients you're serving. But an approach of cultural humility emphasizes self-reflection, open-mindedness, continuous learning, equal respect for different beliefs, points of view, and experiences, and active work to mitigate power differentials. So taking a culturally humble approach can help you to understand and value patient perspectives and deepen the effectiveness of your therapeutic relationships. Okay, that's a lot of context. Now we're going to get a little bit deeper into some of the fundamentals of collecting race, ethnicity, and language data. So on the next slide, I'd like to take a moment to give a little context around the term health equity. This is a term that's always been changing in meaning, and in particular right now, it might be a term that feels a little bit uncomfortable. So we want to take some time to break it down. When we're talking about health equity, we're really talking about several different beliefs and values that motivate us as we approach improving healthcare processes and systems. First, we're acknowledging that people are positioned differently and recognizing that's due to many complex factors, including where they live, the resources they can access, how they're treated by others, and how they interact with systems, and also importantly, how the people around them are treated and interact with systems. Next, we're stating that we believe everyone deserves a chance to access the resources they need to be healthy and lead a good life, while recognizing that health and a good life aren't the same for every person, and the resources needed to achieve that goal are not the same for every person. So a vision of health equity still includes difference and tailoring our approaches. And we feel that the role healthcare systems are best suited to play is to provide evidence-based, high-quality care that helps people to achieve their health goals. And this includes a responsibility to invest and partner with patients, communities, community-based organizations, providers, payers, and more. So let's get into it a little bit. We're talking about race, ethnicity, and language data collection today. So it's important to know what we're referring to. So race refers to the social construction and categorization of people based on their perceived shared physical traits. So this is about how we look and our different features. It's also important to acknowledge that human variation, or our different looks, exists on a spectrum or multiple spectrums, and that it's continuous. We don't exist in distinct groupings. Our biology and our genetics are influenced by many things. However, this doesn't mean that race isn't meaningful, even though there's no clean way to actually categorize people into distinct races. It is meaningful socially and politically, even if there's not exactly a gene to look at or a specific biological definition of race. Because the results of race are the maintenance of a social political hierarchy. So that is why race is meaningful. Really, a lot of times when we're talking about race and how it interacts with the healthcare system, we're talking about people's experiences with racism, which is a system of structuring opportunity and assigning value based on categorization by physical traits. And these levels of racism come from Dr. Kamara Jones, who gave a really excellent TED talk called The Gardener's Tale, which, if you haven't seen that, I would recommend it. It's just a few minutes. But she talks about the levels of racism that people encounter: internalized, which is what I believe about myself; personally mediated, which is what happens in between people based on their expectations and their experiences; and institutionalized, which is the way that we build our beliefs into the systems that we interact with. And ethnicity refers to a shared culture due to common ancestry and a shared history. So that is a smaller description, but no less complex than race and racism. Okay, we can go to the next slide. So as I mentioned, when we talk about race, what we're often trying to reflect is racism. And unfortunately, racism impacts healthcare experiences. So the use of race in medical screening and diagnosis has led to people receiving differential treatment, or treatment later in many diseases, later in the illness, once symptoms are more severe and treatment is less effective. Some common examples of that are the use of race in GFR for testing kidney disease, in PFTs for lung disease, or one that you may be more familiar with,
Hi. Okay.
if you work in
I told Lee to move.
birthing hospitals, is the vaginal birth after cesarean calculator, which uses race as a determinant in clinical decision making, thereby reducing the likelihood that Black and Hispanic women will be recommended for a trial of labor after cesarean. So the use of race in these algorithms reinforces racial bias by suggesting difference, even if there's no evidence other than a shared race or ethnicity. It also is using race as a shorthand for biology or genetics, when race is much more complex than that. The other way that racism impacts healthcare experiences, and I'm sure this is not comprehensive, there are many, but bias and stereotyping shows up in clinical encounters, eroding trust and impairing the ability to provide and receive needed care. So a famous example is this very famous person, Serena Williams, pictured here, who had a history of blood clots and reported her pain and trouble breathing after the birth of her first baby. She even asked for a CAT scan, and she was ignored by hospital staff and reportedly was told by one nurse, "I think all this medicine is making you talk crazy," which connects to a history of ignoring or minimizing Black people's reports of pain. And this goes back to enslavement and myths of higher pain tolerance, which helped to justify their treatment during enslavement. And in particular for the birthing field, the use of their bodies to develop gynecological surgical procedures. So it's important to know about these historical factors and understand that when we ask patients about race, we're asking a very personal question that is also related to individual and group experiences with bias and oppression. But race is one way we think of ourselves and each other, and we can't ignore the impact of race on our interactions. So by recording race and ethnicity in healthcare, we're trying to approximate that more systemic, those components, such as experience of bias, mistreatment, also privileges, access, and so much more. So any individual's race is not something that's a problem or a risk factor, but the way we're treated and interact with the world is the unequal factor that we're trying to assess. And in a world where race and racism do not impact healthcare delivery and outcomes, we won't need to collect this data. But for the present time, it's not helping us to ignore it. We can provide better care if we engage in this complex work with compassion for our patients and for ourselves. And this slide has some risks of opening these conversations around race and ethnicity and some benefits. So you can risk essentializing race in other words, sort of making it central when that's not what you're intending to do, and activating people's mistrust and bias. Also, we know there are issues with categorizing people. You can miss a lot of people or within group variation. Labeling can lead to a tendency to think of problems as individual rather than as complex and systemic. But some of the benefits include it can open up spaces for conversation about a person's experiences. It can help you provide culturally appropriate care and services. And it gives you opportunities to provide information about why you're asking, how the information will be stored, what will be done with the information, and address any concerns about any of the risks that I mentioned above and privacy. So now just a few more slides from me before I transition to Anne. Wanted to give you a sense of the current practice in Colorado. So currently, race and ethnicity data collection in Colorado is based on a requirement for payers or insurance providers that went into effect in late 2019. This mandated collection and submission of one ethnicity and one race field to the Colorado All-Payer Claims Database. The All-Payer Claims Database is a statewide healthcare insurance claims storage. It's the largest source of insurance claims data in Colorado and represents most people with commercial health insurance, Medicare, and Medicaid. And this requirement was originally based on a federal standard from the U.S. Office of Management and Budget, or otherwise known as OMB, which sets requirements for all federal programs, including the census and Medicare and Medicaid. And as you may know, Medicare and Medicaid are major purchasers of healthcare services, and other insurers tend to follow what is required in these programs. So this is likely what you see or something like this in your electronic health record currently as the options for race and ethnicity. It's the ethnicity first, Hispanic, Latino, or non-Hispanic Latino. And then these 5 race categories that you can choose from, along with other and unknown, and it's a single selection for race. Moving forward, you're likely to see in the next few years the updated standards from the OMB, the same source that the current standards came from, in an attempt to be more inclusive of how people identify. In the prior categories, they would frequently hear that people of Hispanic or Latino or Middle Eastern North African descent did not feel reflected by the previous categories. Also, there are many people who identify as multiracial, and if they were not allowed to choose multiple categories, then they would end up in the other category, making their answers less visible in the data, invisibilizing them. So this new system allows for people to select multiple options. It also flips the order of identification and starts with a single question of what is your race or ethnicity, and then encourages respondents to select as many options as apply, and allows for further detailed data collection in the form of additional checkboxes and open-ended data fields, so people can add more details about how they identify. So right now, your EHRs likely contain the 2-question standard, or they could be a simplified version. We also know that the data comes from various sources, and depending on how you interact with it, you may see different things. The insurance enrollment files, as well as Medicaid enrollment, as well as birth certificate data, which Amber will discuss a little bit later in the webinar. And we'll try to cover some best practices for asking about race and ethnicity data later in the presentation. We recognize that categories are not always inclusive, even when the updates are implemented, but a best practice remains to aim for self-identification by asking the questions. Just a few words on language data collection. Language needs may be different for speaking, for writing, and/or the need for an interpreter. So you may see sets of functional language questions, like this example on the right has a spoken language preference and a written language preference, which would allow the printed patient education materials or other materials to be printed in the written language of preference. There are also additional ways that you can think about communication needs, such as large print materials for those with sight impairment. And the part of the reason this is so important is that identifying those with lower English proficiency can help identify disparities, as they're likely to be at a disadvantage in interacting with the system and can have more difficulty accessing primary care. So with that, I'd like to hand it off to Anne to discuss opportunities to enhance race, ethnicity, and language data collection.
Thanks, Vicki. Really appreciate that background and some more understanding on the value of collecting this type of data to better understand the impact racism has on healthcare through delivery and outcomes, as well as some of the risks we should be mindful of when we're starting to collect this data. So I'm going to talk a little bit about how we can go about collecting race, ethnicity, and language data. It's very important to train staff to collect this data because it can be kind of awkward to ask about. Like Vicki mentioned, conversations explicitly about race, especially in a healthcare setting where patients might already be nervous or experiencing difficult health issues, can feel sensitive, it can feel awkward, it can activate feelings of mistrust or fear. So having scripts is one helpful way and one commonly used best practice for providers or administrators who are asking patients directly about race, ethnicity, and preferred language to kind of have a go-to that introduces the conversation and gives them a sense of how to answer common questions from patients. It's also really helpful when training staff not only to provide them with the kind of direct and specific language they might use, but also broader context about how race, ethnicity, and language data will be used and how it relates overall to the health equity and quality improvement work you're doing in your setting. Having that context can make patients feel more comfortable about why the data is being collected and what you're going to do with it. And it might make staff feel more comfortable asking questions because they know they fully understand why they're asking. They understand the value of putting time into this and also how to answer patient questions, like I mentioned earlier. And I think one thing to remember when we're doing this kind of training and starting to talk more explicitly about race and ethnicity with patients is that staff already have experience talking to patients about challenging topics. That's like a key part of working in healthcare is people come in with things they're embarrassed about or afraid of, and you have to talk to them about it. So remembering the skills you and your colleagues already have about leading into sensitive questions can be really helpful here. Remembering what works and what doesn't and sharing that with your colleagues as you start to more systematically collect this data or as you update how you collect data if you're already doing it. And then, as you're training people you work with, thinking about who can be a champion, who can be a go-to for questions and encouragement if rollout is tricky or rocky at different points. So with that kind of overview about staff training, I'm going to jump right into some practical steps that might be helpful for the people on this call today and your colleagues, which is a few examples of scripts around collecting race, ethnicity, and language data. Most of these came from a toolkit from the Agency for Healthcare Quality and Research, which is a federal agency that does healthcare quality work. They have a really great toolkit that we can share a link to around race, ethnicity, and language data collection. And so I drew a lot of examples from here where they worked with care sites across the country to develop REL data collection programs and kind of observed what worked and worked on sharing that nationally. So I have 3 scripts I'm going to start with that really are all about starting that conversation with patients to directly ask them for race and ethnicity data. And for each one, I'll read the script and then I'm going to ask you all to jump in and tell me, based on your experience working with and talking to patients every day, what do you like about these scripts? And is there anything you don't like and you would change if you were delivering them? So feel free to share those in the chat or come off mute and share verbally. So this first script is you would go up to a patient and say, many studies from around the country have shown that a patient's race and ethnicity can influence the treatment they receive. We want to make sure this doesn't happen here, so we use this information to check and make sure that everyone gets the best care possible. So I'd love to hear from you all. Are there things you like about this script? Is there anything you don't like or you would change? Again, please feel free to share in the chat or out loud.
I think it's very well said and very well stated. This is Dr. Dawn Owens Robinson from Advent Health of Vista. I'm part of the MMRC committee. So for the first example, I think it's well stated.
Great. Thanks
I
so
was
much.
thinking as I was warming up my food, the political environment of where we're at may make implementation of this process a little slower because people are going to be more resistant to stating their facts.
Yeah, I really appreciate that, Dr. Robinson, both the clarity of this statement and also potential discomfort people might have with this conversation compared to a year or a few years ago. And we'll definitely talk pretty explicitly about those questions patients might have next. So thanks for teeing me up. Any other thoughts on what you like or dislike about this particular script? There's a couple more coming as well.
This is Crystal. I'm from.
Oh, Crystal, I see you're still talking, but I think it just muted, at least on my end.
I'm sorry.
There you go.
So with this statement, I'm just going by off of what Dr. Robinson had just mentioned. I think a lot of patients will be in fear given this information due to like undocumented and deportation. And I think there would be a sense of fear, even though it could be coming from a white doctor or nurse. Just thinking of those kind of settings and just how careful are we, or even the wording means a lot. And how do we make that a safe space for patients to actually give their information? And like Dr. Robinson said, this will be surely a slow process.
Yeah, thanks so much for that comment. Appreciate it. Maybe adding something explicit about protecting privacy, or depending on the populations you work with, something explicit about you're not asking after citizenship or residency status. This is purely for quality improvement work. I think that could all be valuable, especially given what's going on. I see a comment in the chat from Amy about Native Americans can get lumped into the same race if they check another box. I think that's a great point. I believe in the New Mexico data that this example is from, they have some explicit questions about tribal affiliation, but I think that's another really valuable thing to add and be aware of is that Native American is not, by many people, not viewed only as a racial status, but also as a political status and citizenship or membership. So an explicit question around tribal affiliation could be helpful as well if it's supported. All right. Thanks everyone from your comments. Really appreciate your thoughtfulness. So we'll go to the next one. And just to be clear, I have three and each one gets slightly longer, but I didn't intend for them to be good, better, best. They're a mix. So appreciate your open thoughts here. So the second script, a little bit different. It goes, I would like you to tell me your race and ethnic background. We use this information to review the treatment patients receive and make sure everyone gets the highest quality of care. Any thoughts about this one? Things you like specifically, dislike, would change?
I think you need to put the explanation first.
Mm-hmm.
You need to explain why you're collecting the data. It seems, yeah.
Mm-hmm. Okay, so
I-
people might feel like it's very abrupt starting with the
Mhm.
question directly as opposed to starting with some background. That's a great thought.
An example, my niece came to my practice to see one of my colleagues last August, and my sister called me on the phone. Why are they asking about her race? Why is that important? So now I think explanation first and then maybe the ask.
Mm-hmm. Yeah, I think that makes sense. I work on this professionally, but I was a while ago at an urgent care site filling out information and it asked me race and ethnicity. And it was on like a patient intake form, no context, a huge long list. And it just felt like, I mean, I know why they're doing this, but it felt very contextless, very impersonal. So I definitely appreciate that. Any
I
other
think
thoughts?
it provides a little bit more reassurance if you do that as well.
Mm-hmm. Appreciate it. Thank you.
And I would like to say too, like, I would like you to tell me that is kind of being like forced for the patient instead of asking them for their permission for the provider to ask for the race and ethnicity background. Ask them for that. I don't want people to feel forced into giving their information as well, because that can be it's obviously inequitable.
Mm-hmm. Yeah, I appreciate that, Crystal. And someone else in the chat mentioned feeling extractive, and I think those two things are related. Framing it more as a partnership, as a would you be comfortable with sharing, might get you a little bit further, make patients feel more like they have an option to say no, which they certainly do, and we want to make that clear. Okay. So I'll hop to the third script. This one's a bit longer again. It goes, we want to make sure that all our patients get the best care possible. We're going to ask you some questions regarding your race and ethnicity so that we can review the treatment that our patients receive and make sure that everyone of every background gets the highest quality of care. We are also going to ask you about the languages that you speak and understand. If you prefer a language other than English, we will try to find someone to speak to you in your preferred language about your health. The only people who see this information will be members of your care team and others who are authorized to see your medical record, so your answers will be confidential. So this one a bit longer, and I think it addresses some of the things you all have already brought up about providing a more comprehensive explanation, ensuring confidentiality, and patients understand privacy up front. It's also a bit of a mouthful, so I could see that being somewhat of a drawback, but curious if you all have any other thoughts about likes and dislikes here.
I know I was late to the meeting, but I got, sorry. Is this going to be in print? Are they going to be able to read it too, or is it just going to be spoken to them? Because that's important because learners are different. And my colleagues will tell you, and my nurses who are on this call, I'm OCD about documentation. So I agree this hits all of our concerns about safety, what's going to be done, and a thorough explanation, providing a translator. But I think we should, just with our consents for everything else, we admit them to the hospital. It should be something they should be able to read. They can think about it before it's even brought up. So I think it should be in print too, especially if it's this length.
Mm-hmm. Yeah, I think that's a great suggestion. Thinking about different tools to support collection, having a conversation, offering it in print, offering it on like computers as well as paper, knowing some patients are much more or less comfortable with kind of the iPad system of checking into appointments that we see so much. So thank you for that. All right. And I also wanted to see while we're here kind of looking at these scripts, are any of you already collecting this kind of data where you work? And is there a script you use that you want to share either verbally or in the chat or some key points of it? Because I think, as well as looking at some best practices from around the country, you all may have things to share with each other.
I know that we're working on doing some things that we have not gone live with at my hospital. This was one of our goals. But I know like at this point, probably our hospital just obtains a lot of this information in their outpatient visits as well as registration when they check in. Otherwise, I don't think, we don't ask it on our unit.
Mm-hmm. Okay. I think that's a really good point is different sites of care are going to have different workflows, which is something we'll talk about not in as much depth in a moment, but making sure as a system, where the patient is being asked this question, how much it's being asked, and who should and also who shouldn't bring this up, because you don't want to ask them every single doctor they see in a health system. It's not necessarily helpful. So very good point about kind of it may be you, but it may also be not you who's doing this kind of data collection. Okay. All right. Well, thanks everyone. So those are some scripts really for getting the conversation started, right? And as a group, we talked a lot about providing background information and giving context around privacy and confidentiality. I think those touch on some of the questions you might hear from patients, whether it's you or your colleagues who are asking these questions. So again, like I mentioned earlier, one of the other kind of recommendations when putting into place data collection programs for race, ethnicity, language, or other personal data from patients is helping staff be prepared with potential frequently asked questions and ways that they can respond to those questions. Obviously, every question might be a little different. You may need to personalize or adapt, but I think some of these examples can be helpful for getting a sense of what people might want to know about this kind of data collection and what responses make sense given your setting, your workflows, and how you all operate. So someone might answer a question around, what's your race, what's your ethnicity with a response like, I'm American. It can be hard to know what to do with that. So I think this, response we have here in the light blue about, would you like me to put down any additional terms or just American can make sense, right? When we're talking about ethnicity, most people in the US came, their family came from somewhere at some point, but some people are pretty far removed from that and may not really think of a different cultural or ethnic heritage for themselves. Other people might be saying, I'm American, but when you probe a little bit further about additional terms, might say, oh, well, my family's, Irish American or Asian American, and they might want to end up, putting multiple responses if that's possible in your EMR. Some people might say things like, can't you tell just by looking? Thinking back to what Vicky said about race is, not biological, but really just about appearance and perception in a lot of ways. In this case, it's really helpful to recall that self-identification is key. It's what we want as much as possible when we're collecting and using REL data. So it might be helpful to respond something like, sometimes I can, but I also might be wrong. I'm trained to ask instead of making any assumptions, so we know our information is right. That gives the patient a little bit more information about kind of why you're asking the question instead of just checking off some boxes and not engaging in the conversation. And it clarifies that you're looking for accurate and clear information, which I think can be really helpful for understanding why you're having the conversation. People might also ask a question that probes a little bit more about the context of this conversation or shows that they're a little bit uncomfortable talking about race explicitly or engaging in this conversation. For example, the dark blue at the bottom. Why do you care? We're all human beings. That might be an attitude you've heard quite a bit from people if you talk a lot about health equity and racism and race-based outcomes in healthcare, racism-based outcomes. So you might have an answer something like, well, studies from around the country have shown that a patient's race and ethnicity can influence the treatment they receive. We want to make sure this doesn't happen here, so we use this information to make sure everyone gets the best care possible. If we find a problem, we fix it. I think this really gets at some of the conversations we had earlier about addressing the why for collecting this data, giving patients a little bit more comfort that your goal in collecting this data is understanding potential disparities and solving those disparities as time goes on. I'm going to walk through a couple more other potential FAQs patients might have. If there's anything you've heard frequently from patients or you worry about knowing how to answer, please feel free to also throw those in the chat and we can discuss a little bit more as a group. But as Vicky pointed out during our intro, people might have questions about what is meant by the terms race and ethnicity. They're terms that different people use in different ways. In this case, it might be most helpful to provide patients with their options for response to help them choose. And whether you're using the slightly older two-step option that Vicky pointed out with, ethnicity and then the 5 racial categories, or the newer standards about, the 7 and you can check multiple race and ethnicity categories, that'll make a difference because you want to help people self-identify, but you also need to collect data you can actually record and you can actually use. So you might lead into it by saying different people talk about race in different ways. For this question, I'm asking if you identify as, and then list your options. So white, Black or African American, Asian, American Indian or Alaska Native, Middle Eastern or North African, or Native Hawaiian or Pacific Islander. If they're asking about ethnicity, which for some people is a concept they really understand innately because they're very linked to their culture, and for some people can be a question, it might be helpful to say something like, in the United States, we often talk about ethnicity as being Hispanic or non-Hispanic. So that's getting at that two-question form that many of you might have seen. However, more broadly, ethnicity refers to your culture and your heritage. And then you can kind of think about what kind of data you can collect and what you want to hear, how you can prompt self-identification from the patient by saying something like, you can share with me whether you are Hispanic or not, or what country or countries your family comes from that influence how you live your life, kind of getting at that definition, but also helping give some clarity around the ways people can answer the question. To some of the points earlier, people might also ask questions about citizenship, especially in the current political climate. And the number one important response here is to make sure patients feel safe in this healthcare setting. So being really explicit by saying, whether it's upfront or in response to questions, I'm not trying to find out about your citizenship or residency status. I'm just asking about your racial and ethnic background, and any information I collect will be kept confidential. Can be a helpful way to be extremely clear and explicit if that's something you can safely do at your organization or can authentically say about protecting that kind of information for your patients. They might have questions to you about how they identify. It might be something they haven't thought about before. Something like, well, I was born in some country, but I've lived in the US for most of my life, in this example, Nigeria. Again, this kind of calls back to self-identification, and similar to that first question, sharing the options they can answer and helping them think through what's most authentic to themselves and how they identify. And finally, it's quite possible that some patients are just not going to want to answer this question, whether it's for privacy concerns, discomfort talking about race, or any other reason we might not be able to think of in the moment. So they might say, I'm just human, or it's none of your business, or I don't want to answer. And it's really important too that we don't turn this into a fight, into extracting information people don't want to share, but rather always allow a patient to decline and let them know that decline is clearly recorded, so they're not repeatedly asked this question over time while seeking healthcare. So those are kind of some of the scripts and the conversations that are important to have when trying to improve collection of race, ethnicity, and language data. There are lots of other topics for staff training that we're not going to have time to get into today, but that I wanted to raise as you all think about integrating and incorporating data collection into your own work. First, understanding the patient experience or journey can be really helpful. Knowing who asks patients for their REL data, as someone pointed out earlier, when the patients are asked and how often data is collected, making sure it doesn't feel like something they're always being asked, or, conversely, they were asked one time 8 years ago and, they might have new or different information to share. And also understanding the staff role. Understanding if there are aids you can use if patients don't understand the question. For example, that written script that people talked about earlier. Knowing where data is recorded, who can access the data, how it's used, and who to go to with additional questions are all things staff should be trained on when they start collecting this kind of data. And then I just did this blue box linked to some other training tools, again, from that toolkit from the Agency for Healthcare Quality and Research. Looking at tools and trainings used in other settings, you might have to change it for your own EMR, your own workflow, but can be really helpful for seeing what's helpful to train staff on and where there might be common questions or pitfalls. So I'm going to turn now to Amber, who's going to share for a couple of minutes about some of the work the Colorado Perinatal Care Quality Collaborative has done to collect race ethnicity data on the patients that you all work with and care about. So Amber, I'll pass it to you.
Great, thanks, Anne. Even though the conversation that we've had so far today applies to data collection more broadly, I do want to take a couple of minutes to link this conversation to the work that CPCQC is doing to improve maternal and infant health outcomes. So Turning the Tide, as you can see here on the left, is a hospital-based quality improvement initiative that supports substance use screening, brief intervention, and referral or initiation of treatment during the hospital birth admission. We promote universal screening, and in that you can sort of hear that all patients should be screened regardless of age, race, payer status, language. CPCQC's SOAR Primary Cesarean Reduction Initiative promotes safe vaginal birth, and it decreases non-medically indicated cesareans for first-time low-risk birthing people. First-time low-risk birthing people is a target population because of the quickly rising C-section rates among this population, as well as the long-term reproductive risk that these patients carry after a first cesarean birth. Even within this target population, there are differences in rates of vaginal versus cesarean births by race, ethnicity, and payer. CPCQC's quality improvement initiatives, including the two on this slide here today, are based upon AIM patient safety bundles from the Alliance for Innovation in Maternal Health. These bundles support the collection of race, ethnicity, and payer data because disparities in maternal health outcomes are deeply rooted in systemic inequalities. Collecting and stratifying data by race, ethnicity, and payer status allows us and then our healthcare teams that we work to identify disparities in outcomes, for example, severe maternal morbidity, mortality rates, or even access to treatment. It helps us monitor equity gaps real time. It helps us to hold systems accountable for the experiences that patients have within their hospital care settings. It also helps us to design and evaluate interventions that can be tailored to the needs of specific patient populations. And it helps us ensure that our quality improvement efforts are not inadvertently widening disparities in patient populations. You can go ahead and go to the next slide. Currently, CPCQC closely aligns our data collection here on the left, you can see, with all payer claims database, where we asked separate ethnicity and race categories. We chose to do this to closely align with what we hear from hospital systems and what is in their electronic health records, and also how data is collected within vital statistics on birth certificates. CPCQC leverages birth certificates as a source of data to decrease the burden on frontline healthcare providers and hospital systems. And we know that standardizing how we collect data with databases such as vital statistics and birth certificates help us to be able to benchmark our data from hospital to hospital and from state to state. We do plan to continue to sort of push forward and move forward with more closely aligning to the OMB method that we discussed earlier, where patients can select multiple options. There's a single question for race and ethnicity, and there's options to select all that apply. But this decision always has to be balanced with our access and available data sources, like I said, currently electronic health records and vital statistics, and the consistency of the data across those sources. So it is a bit complex, and that's why we're here today, to use these webinars to raise awareness for how we can continue to improve this data collection. The next slide is an example of how CPCQC uses our race and ethnicity data to identify difference in healthcare outcomes. We help hospitals track C-section rates for low-risk birthing people. And as you can see here on this statewide data, we have identified that birthing people who are identified as Black have higher rates. And you can see that in the second bar column there. And conversely, people who identify either as other or white Hispanic have lower C-section rates among low-risk birthing people. I think this slide is also important because it demonstrates some of the limitations of our current race and ethnicity data. So as you're looking at this slide, I'd like for you to consider what race and ethnicities are not clearly represented here. And you're welcome to use the chat to identify that. What are the dates for this slide? That's a great question, Dr. Robinson. This is data from 2024. It's Colorado-based data from Vital Statistics.
Great. Thanks, Amber. Really appreciate that example of how you all are looking at collecting and using REL data. In the other webinars in this series, we'll try to continue to highlight some very specific examples from Colorado as it's helpful for you all thinking about applying these concepts into your own quality improvement and health equity work. So I'm just going to wrap up my section with some next steps for potential consideration. We're focusing most explicitly on race, ethnicity, and language data in response to Colorado law, and also in response to where we see health equity work going. But I wanted to highlight too that there are multiple different types of disparities we see in healthcare in Colorado and across the country, including disparities in care and outcomes for LGBTQ plus people. So some organizations around the country have begun to explore collection in addition to REL data of what they're calling SOGI data, sexual orientation and gender identity, to identify those disparities among that population. Similar to our conversation about sort of citizenship status, I think SOGI data collection might be particularly sensitive for patients in the current political environment. So some organizations who have started doing it are thinking about how to approach it sensitively and carefully. especially, in the setting of more politicized gender affirming care. I'll point out that Colorado has multiple protections for LGBTQ plus people written into law, including protections for access to gender affirming care, but wanted to note this is, a potential next step for organizations as they're thinking about potential disparities among the populations they serve and how they can identify and start to work towards mitigating those disparities. And for example, an organization that collects SOGI data collection might record it something like this in their EMR. You can see there's a distinction in the second example between the legal name and the preferred name, with the preferred name being given top billing so the provider knows what to call the patient. And then a flag that the patient is non-binary and uses they, them pronouns to make sure that the provider, when they're looking at the patient's data, can refer to the patient as they prefer and create a respectful and trusting care setting. So that's one potential use of SOGI data collection and one way it could show up in a medical record. The second potential next step I'll touch on briefly is presenting REL data. So I know the point of presenting this data is to use it, similar to the graph Amber just showed us, using it to identify disparities in how we're providing care to people and the outcomes they're experiencing. I wanted to share some tips from Urban Institute's Do No Harm Guide, which is a really good guidance and checklist to help think about presentation of health equity and disparities data. Some of their key examples or some of their key best practices include being clear, using direct and descriptive language instead of obfuscating, being person-centered by focusing on how people describe themselves. People don't really call themselves other. Is there a way we can identify more specifically race and ethnicity data or the terms they would use to describe themselves? Being intentional by considering the implicit norms when ordering data and selecting colors and icons. That's the example we have on this slide, where in that figure 12, you can see a color scheme that uses a gradient of colors. One, that's just not very good data presentation because it's very hard to tell the difference on a graph between the red used for Native American and the red used for Native Hawaiian. But two, gradients can sometimes imply hierarchy. It's not explicit, but it is implicit. So they suggest that figure 14, a very different color palette that doesn't have sort of a deeper, darker, better, best concept to it, and that's also more clear to read. And finally, being mindful, thinking back to the introduction that Vicki gave so well, and providing context around the causes of health disparities. We often see things like Black women experience greater rates of maternal morbidity. Highlighting that it's not race that's causing that, it's racism, and that, due to racism, due to systemic discrimination, we see higher rates can be a good way to kind of frame the context around the causes of health disparities, ensuring that we're not building on this myth of biological, imperative. So again, no time to kind of get super deep into it, but just wanted to point out that many people kind of take this idea, collect the data, and want to go ahead and start digging into it. And being mindful about data presentation is a really key next step. So I'll share a few takeaways and then we'll have a little bit of time for question and answer. Approaching REL data collection as a conversation with patients can be the most successful way to open doors. Showing and flexing cultural humility is really key to get patients comfortable asking you their questions and sharing this data with you. Prioritizing self-identification to the greatest extent possible within the constraints Amber mentioned about how we collect the data, where we record it, and who we need to share it with. And then, of course, providing staff with the training and context needed to be comfortable in this conversation can be really valuable. And thank you, Sarah, for your comment in the chat about not comparing against white as the default. There's some really good resources out there we can share after about benchmarking when you think about disparities and some pros and cons of different types of benchmarks for disparities data. So really appreciate that shout out. All right. Any questions? Feel free to put them in the chat or come off mute.
I have a question, Dr. Owens Robinson. So why does she feel that white should not be the baseline comparison? Or why do the studies, let's not call her out. Why do the studies and surveys feel that that should not be the baseline for comparison?
Okay, I'm going to try to give a really concise answer here. And Anne, feel free to hold me to account. But, the basic idea is that the way the system of hierarchy and supremacy is not serving any of us. That actually we all would be better off with a system that provided for us as individuals, that saw us as individuals, and that didn't use our appearance to group us and just determine what type of treatment we deserve. One resource I would point to is a book called The Sum of Us by Heather McGee. And that is the whole argument is we should not have a zero-sum mindset where in order for certain groups to have better resources, that means taking them away from someone else. So that implies that we all have room to improve health outcomes. We have room to improve the health system as a whole, and everyone can benefit from that. So it's the idea of universal goals rather than everybody catching up to what one group has right now.
So I guess the data collection will have to catch up to that because now it's just by, it's by race. Because I'm doing a TV interview tomorrow in person in the studio. And when you said that, I was just typing that not wonderful, but that up-to-date statistics about C-sections in Colorado. And I was literally typing versus white women or versus white counterparts is what I usually say. So I may just sleep on how I'm going to phrase that differently.
Mm-hmm. And I think too, it's not necessarily, I think different people have different schools of thought on the best comparison, but thinking through who you're comparing to and why and being able to justify can be helpful. So I linked to an article in the chat that I think it doesn't say, don't compare to white so much as some of the pros and cons of comparing to white, comparing to a population average, comparing to the best performing group, regardless of race, because we know for different kinds of healthcare, white people are not always like the people experiencing the best outcome. So I think it's nuanced but interesting. All right, we're gonna take a moment to close out. I will pull my screen back up. Thank you for your question. Okay. So wanted to flag that we have 2 more webinars in the series coming up. One about understanding quality improvement with a health equity lens on May 20th at this same time, and one about strategic communications about health equity and data collection on June 24th. You can register for those at the same link you used for this one if you haven't already done so.